Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, and welcome to the latest video podcast in the Medicine Journal series. My name is Albert Ferro. I'm the Editor-in-Chief, Chairman of the Editorial Board of Medicine, and also a clinical pharmacologist. And with me today is another clinical pharmacologist, Dr Andrew Hitchings. So welcome, Andrew.
Hi, Albert. Nice to be speaking with you.
Nice to speak to you as well. And the reason we've got two clinical pharmacologists is that we're going to be talking a little bit about the clinical pharmacology issue of medicine, which has just come out now in January 2024. So we're going to sort of talk a bit around clinical pharmacology and maybe highlight one or two things from that issue. So Andrew, welcome to you, and perhaps you could maybe just start off by telling us a few words about yourself.
Yeah, of course. So I'm a funny mix of different specialties. As you say, I'm a clinical pharmacologist, but and I work at St George's, both in the university and in the trust as a clinical pharmacologist. But my actual clinical practice is as an intensive care consultant. So I work on the neurointensive care unit at St George's. I've got a number of hats in clinical pharmacology sense, in that I do a lot of education. So I run the final year exams, for example, for the medicine program at St George's. I also do quite a lot in the world of medicine's appraisal. So I run the formulary committee for South West London and sit on several nice committees, helping to develop guidance on how we best use medicines. I've had a bit of a role in research in the past, but my main work at the moment is, as I say, in education and in medicine's appraisal.
So you're obviously a very busy man, and I think one of the things that I wanted to just start off with is what do we mean by clinical pharmacology? What is a clinical pharmacologist? I find myself that when I tell people, including other doctors, that I'm a clinical pharmacologist, they'll always look at me a bit blankly. And so I have to explain a bit about what it is. It's a bit of a far-reaching term, isn't it? What's your view? What is clinical pharmacology? What is a clinical pharmacologist?
Yeah, so you're right. It can be a bit difficult to define, can't it? I mean, we can, if you look at it from in a practical sense of what is a clinical pharmacologist, by and large, they are physicians. So they're usually doctors working in the NHS or possibly in the pharmaceutical industry, usually with clinical training in general medicine, but with a specific skill set and body of knowledge that has come from their training in clinical pharmacology. So that's the sort of practical definition. But actually, I like to think of it more philosophically, that the clinical pharmacologists are people who bring, as I say, a body of knowledge and a skill set, but also an approach that is different to most other hospital specialists, at least. So where increasingly in hospital specialties there is specialism and subspecialism, there is typically an organ focus, there may even be a specific disease area focus. Clinical pharmacologists are somewhat different in that we take the approach of the medicines and how do you get the best value and the best outputs from the medicines that patients or populations are receiving, which I think is a different way of approaching things, which is complementary to the disease focused or specialty focused approach that our colleagues would have, but it brings a useful different perspective, I think. Probably a greater appreciation of risk, of real world complexity, of the interplay between patients, their diseases, their drugs, the interactions between the drugs, and the real world effectiveness of medicines, as opposed to the effectiveness that is portrayed in clinical trials, which we would term efficacy as opposed to effectiveness. So that's maybe this is part of the problem of the difficulty defining ourselves, is that there isn't a simple one-line definition. But I think that's part of the strength of the specialty, is that it's as much about an approach and a skill set and a body of knowledge as it is about defining a specific area of practice.
I think you've illustrated that we have some commonalities, but we're also quite diverse as well, aren't we? So there are things in common. We all have some expertise around drugs and their usage. We teach around that. We do research in that. And we also all have our specific specialties as well. Many of us, like myself, are hypertension type doctors. But then you, for example, you're a neurointensivist.
Yeah.
And then there are other sorts of clinical pharmacologists as well, aren't there?
Absolutely. I mean, just to take St George's as an example, we have my colleagues encompass areas of practice from intensive care, as I do, respiratory medicine, cardiovascular risk, maternal medicine, acute medicine, and that's just at St George's. And if you look more broadly than that, you'll have people involved in, obviously, toxicology as one significant strand of clinical pharmacology. And then you can even look beyond clinical practice to include the pharmaceutical industry, drug regulation, medicines appraisal, as I was talking about before, the BNF. There are so many areas, and then I haven't even started on education, but of course that's another one. But yeah, very diverse.
Very diverse. And of course, this issue is all around some of the issues that you've mentioned, including, areas of prescribing, which are common to all doctors, really, areas around, optimizing medicines, if you like. Maybe we could highlight some particular areas that are covered in this issue. So one, I think, perhaps would be prescribing errors. And I know you feel that that's an important area, isn't it?
Yeah. There's an article in this issue by Simon Maxwell in which he discusses the process of prescribing and how to avoid errors, and I think that's a really important article in the chapter, and a really important issue generally, because it's one of the things that illustrates the clinical pharmacology approach, the appreciation that you may do a big clinical trial that demonstrates the benefit of some new medicine. You may put huge amounts of work into generating evidence-based guidelines, but if they fall short at the point of implementation, then all of that effort is wasted, and the patient doesn't experience the benefit, maybe because they don't get the drug that they were supposed to get, or maybe something's prescribed in a way that's actually harmful for them, because of a failure of implementation, of which prescribing errors is one example of that. So I think it's an important article to highlight that issue, and both in a direct sense, because so I have an interest in this in my role as an educator. One of my particular focuses is in training our prescribers, particularly in the undergraduate sector, but also postgraduate as well. So I think it's of direct importance in optimizing the delivery and quality of healthcare. But it's also interesting that it is, in a sense, a case study of the clinical pharmacology approach, appreciating that the benefit of healthcare is not simply about research and coming up with good guidelines, but it's about actually implementing it in the real world, and implementing it correctly in the real world. And that is necessary to to realize the benefits that have come from all the effort that preceded it.
Absolutely, it's part of it's the benefit, isn't it? But also the dangers of inappropriate prescribing.
Yeah.
And I mean, I think it's clear that a lot of unnecessary hospitalizations, extensions of hospital stay,
Yeah.
morbidity in general, even mortality
Yeah.
can be down to prescribing errors.
Yeah.
And yeah, errors happen, don't they? I mean, part of it is an education thing, isn't it? You know, we have to make sure that people are properly educated. But there are also mistakes, aren't there? Human errors. There are all sorts of reasons why these errors occur.
Yes, and that's something that Simon's article discusses well. I think that it sets it in the context of the system. So it is not just about an individual prescriber making an individual mistake for an individual patient. It's about the interplay between the patient, the medicines that they're on, the prescriber, the prescribing task that they have, and the system in which they're doing it. And it may be that the error is not due to some lack of knowledge, but due to the complexity of the system in which they're working, the pressures they're under, the competing priorities that they have. I think a good example of this is in calculation errors. So we know from the work that Simon has cited that incorrect doses are one of the common types of prescribing error. And I always think back to an example of when we were creating guidelines during COVID, obviously a very rapidly moving situation as it was at the time, and we were putting together guidelines on the use of low molecular weight heparin in critical care patients, and that in the initial form involved a calculation, and we had a number of incidents in which there were major dosage errors related to a calculation. They were very simple calculations, and no one was ever suggesting that the people who made those mistakes don't know how to multiply a body weight by 100 or whatever the calculation was. But it was because of the context in which they were doing it. They were working in an unfamiliar environment, and it was in the middle of the night, and there were multiple distractions, and their cognitive bandwidth was so impaired. And so the system created the circumstance in which the error could occur by, under all that pressure, asking them to do a calculation. And they got the calculation wrong. And so when you're putting the guideline together, you think there's all these advantages from the precision that comes from a body weight adjusted dose, but that precision is made meaningless, and quite the opposite if that then introduces an error that means that someone gets 10 times the dose that they should have got. And you may be better off actually getting rid of the calculation and just turning it into a simple dosage bands, for example, that don't involve any calculation. You sacrifice a little bit of precision, but you make it safer and easier to implement, which may bring about the best outcomes overall, even if from a very sort of purist standpoint, you might have preferred to have something more precise.
And people often think, don't they, that electronic prescribing systems will, you know, make a lot of these errors obsolete. But I don't think that's the case, is it? Because people, it's very well known, isn't it, that people will just sort of click through warning messages just because of the sheer number of those that they get. Some of them are trivial and so on. So very important to appreciate the scale of the problem and how to avoid it. Maybe turn to another article in the series around appraising clinical trials. I know you mentioned that earlier on when we were speaking, and how to appraise them. And obviously, if you're involved in clinical trials running, that's obviously important. But actually, it's something that all doctors really need to know about, isn't it?
Yeah, definitely. And I definitely wouldn't want to sort of go down the route of teaching people how to read a trial report. The article that's in the journal discusses that very well in terms of the practicalities of it. But I think, again, just taking a more philosophical view about the the topic. I think something I alluded to earlier is the difference between efficacy as measured in a clinical trial and efficacy, or effectiveness rather, which is what you actually see in real life. And I think that that's something that's often underappreciated. The controlled environment of the clinical trial, the highly selected population, the reduced or eliminated comorbidities of that population, and the consequent effect that has in reducing drug interactions. Which is all understandable when you're designing a clinical trial, because you want to design the trial in the population that's going to gain most benefit and be least at risk of harm. But that produces a biased estimate of the real world effect, biased both in the extent of that effect, but also in its spread. And I think that's probably underappreciated as well, is that people may say, well, if I was to sort of select a population that was similar to the population in the trial, I can replicate it. But actually, real world population is just so much broader, and the spread of effects will be much broader than the trial suggests. So there are lots of really important issues in looking at the body of evidence that we create our guidelines from, and something else that of course has to take account of is that you can only see the evidence that you can see. There may be more evidence that you can't see, and that brings in the question of publication bias, doesn't it?
Absolutely. No, that's all. And I think part of the message needs to be got across is not only are the results of clinical trials not necessarily directly applicable to a general population for the reasons you've talked about, but also, actually, is the trial really, are the headlines from that trial really justified? So was the trial well designed? Was it adequately powered, etc.? And you kind of imagine, well, if it's published in a reputable journal, then probably it was. But I think it's always worth people being, critically appraising trials when they read them. And also, as you exactly say, is it really applicable to the kind of people, the population that I'm seeing?
Yeah. Absolutely. We often talk about how in a sense, the best evidence is the evidence that comes from the meta-analyses of multiple trials. But if those multiple trials are a biased selection of the evidence, then the meta-analyses will give you the wrong answer. And there have been loads of examples in the past, haven't there, of meta-analyses of multiple trials that have suggested the benefit of a treatment, that when that's tested in a large clinical trial, that benefit no longer exists. So really important.
So, and the one other thing I wanted to allude to under clinical trials was the newer kinds of trials. I'm reminded in particular of the platform type trials, which really sort of found a place during the COVID pandemic, didn't they? And that's a kind of new way of trialing multiple drugs and evolving the structure of the trial during the course of during its lifetime.
Yeah, absolutely. It's exciting, isn't it, to see, and not to say that they were new in COVID, but that was where they really proved their worth, didn't they? And perhaps we should just clarify what we mean by a platform trial. So a traditional clinical trial will generally be set out to test a specific intervention. It will define a research question associated with that intervention, recruit a population of patients to test it in, and try and come up with an answer to that. And it's for anyone who's been involved in a clinical trial, we all know how enormously burdensome and expensive they are to set up. And it seems remarkable that at the end of it, you just dismantle everything and say, well, we've done the trial, analyze the results, and set it aside and come up with a proposal for some new trial, which involves restarting it all again. Whereas a platform trial is open-ended. So instead of being focused on a specific intervention, it's focused on the disease area, and it can test multiple interventions in that disease area or in that population, and it can do so in a way that is adapted over time. So you can bring in new interventions. You can take those interventions that have proven benefit and move them into the control group so that it becomes part of standard care, and then you can test the effect of adding new interventions on top of that. And you keep the trial infrastructure as opposed to having to put it back together every single time you want to create a new study question or answer a new study question. So yeah, really, really interesting.
Yeah, no, thanks, Andrew. Yeah. Maybe just finally turn to one of the other subjects that's covered in the issue, and that's the issue around polypharmacy and deprescribing, which is obviously very topical at the moment. We have an aging population, and therefore, and for other reasons, because of our success in treating and keeping people alive, we have more and more people out there with multi-morbidities, and so needing more and more drugs. So that's part of the problem about polypharmacy. And then there's the issue around deprescribing, about thinking about when a drug is no longer needed and could come off. So these are quite important questions. What's your take on the scale of the problem, and how can we tackle that?
Yeah, so polypharmacy, I don't think it has a single definition, does it? People pragmatically will define it as greater than 10 medicines or something like that. But of course, we have to acknowledge that there are situations in which being on multiple medicines is the right thing. But there are also clearly situations, or perhaps I should say, the more medicines that you're on, the greater the risk that there will be problems associated with that there will be drug interactions or drug disease interactions. And undoubtedly there are situations in which polypharmacy morphs into another term that's used, which is overprescribing, isn't it? Which is prescribing that is not realizing the benefits that it is intending to realize. You asked about the scale of the problem. I think that the article quotes that about 1 in 20 patients are on more than 10 medicines. It's and clearly that increases very much with age. I think it is a big problem. And again, not to want to keep banging on about the clinical pharmacology approach to things. This isn't by any means something that's just the preserve of the clinical pharmacologist, but it is about taking a different approach to the way that we manage and work with our patients to ensure they're on the right medicines to give them the best outcomes overall. The problem that we've got is that we've got a model of guideline production that by and large focuses on guidelines for single diseases. And we've got a model of service delivery, particularly in the acute care and secondary care areas, that again, typically is organ-based, disease-based. And what you may lack, as I say, particularly in secondary care, is the holistic perspective of looking at the interplay between the patient, all their diseases and all their medicines, and maybe taking a more pragmatic approach as to where the benefit is coming from. And services are being developed to address that. So I should plug the St George's service. My colleague, Professor Emma Baker, has with others in the team, has set up a polypharmacy clinic, which is designed specifically to address that need. It is to approach things differently. It's to approach things from a holistic, patient-centered perspective, as opposed to a disease-centered perspective. And I can see the problem I experienced the problem myself as a prescriber, because you have these guidelines in front of you. They tell you that it's evidence-based. You should be implementing these treatments. You're going to be audited against it. There may be, in primary care, there may be financial targets that are tied to it. There's certainly a sense of peer approval from your colleagues if you are seen to implement evidence-based practice. But when you multiply that over the multiple disease areas that a patient may have, they may accumulate so many medicines that you find yourself in the situation of one nice phrase that is used in the article is the prescribing cascade, where you start a medicine to deal with a problem that a previous medicine has caused, and you end up chasing your tail, and the patient ends up on an overwhelming number of medicines that they maybe can't take, or maybe don't take, or that maybe interact with each other or cause problems. And it's the solution to it, I think, in part at least, is coming at it with a different perspective. It's coming at it from a holistic, patient-centered perspective rather than a disease-focused approach.
Clinical pharmacology, in fact.
Indeed, yeah.
Yeah, no, that's really really interesting. I think we're probably running out of time here. I just wanted to maybe plug one other article in the issue, and that's the one on pharmacogenetics for the prescriber. We won't necessarily need to go into that because I've done a separate interview with Professor Munir Pir Mohammed, who's a world leader in this area. And what I do is point any viewers to that other video, because got some really interesting insights by Munir on where we are at the moment with genetics and genomics and where we hope to be in a very few years' time. So I certainly recommend that. Andrew, thank you very much for having chatted with me today. Thank you very much indeed.
Pleasure. Thank you for having me along.